Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I will be discussing some more challenging lupus cases with Professors Andrea, Doria and Maria Dall'Era from the Lupus Academy Steering Committee. Andrea and Maria, welcome, and thank you so much for joining us today. The first one, Maria, is your case. So let's review the case history. A 28-year-old woman presents with a malar rash, nocturia, puffy eyes and swollen feet and ankles of 4 weeks duration. Her medication included ibuprofen for headaches for the past 6 weeks. A physical exam is notable for blood pressure high, 17 to 9 centimeters mercury, pulse was 80, periorbital swelling, erythema with edema in malar distribution, 2+ bilateral pedal edema with normal heart and lung exam. Her labs were notable for leukocytes were normal, hemoglobin 9, platelets 130, and the ESR was quite high, 100, sorry. A decreased renal function with estimated glomerular filtrate rate was 55, and urine analysis showed 5 to 10 red blood cells, 5 to 10 white blood cells, and spot urine ratio was 5.4. She also had anti-nuclear antibodies 1 to 3020 speckled, anti-dsDNA pretty high, 142, and lupus anticoagulant and the low C3. At this point, the systemic lupus erythematosus should be made the diagnosis based on malar rash, ANA positive, dsDNA titers, and low complement, and most probable lupus nephritis. Maria, for educational purpose, can you please highlight what is the clinical kidney syndrome, and should this guide us to decide to do a kidney biopsy or not?
Yes, thank you, Raquel. So I think that this case brings up some interesting learning points even from the beginning. The first is that lupus nephritis can present in different ways in a person with lupus. In this particular situation, lupus nephritis was the presenting manifestation of lupus, along with some other extrarenal manifestations, such as the malar rash, for example, that led us to diagnose lupus. In other patients that we take care of, they may already have a diagnosis of lupus, and then over the course of time, as we're screening them for the potential lupus nephritis, they develop lupus nephritis. And we know that organ-threatening manifestations like lupus nephritis tend to occur in the first 3 to 5 years of the disease, although there are exceptions, which is why we always have to continue to screen patients. But in this particular case, it was the sentinel manifestation which led to the diagnosis of lupus. And I think the other thing is here you have a patient that has clear urinary abnormalities with red cells, with white cells, with a urine protein to creatinine ratio of 5.4. We know that there is likely something happening in the kidneys. We're worried about lupus nephritis. We recommend that a biopsy be done for definitive diagnosis. And in this particular patient, what was interesting was she also has some potential alternative diagnoses brewing in the background. For example, she has a lupus anticoagulant. So does she have antiphospholipid antibody nephropathy? We would only diagnose that on biopsy. And then she also had been taking nonsteroidal anti-inflammatories for headaches. And we know that nonsteroidal anti-inflammatories can cause a minimal change disease. They can also cause a membranous nephropathy. So all these things were going through my head. And that is why diagnosis with a biopsy is critical, so we can rule out mimicking conditions. We can make sure we know what we're dealing with. And then lastly, with the biopsy, we've also learned over the years that urinary parameters, such as the presence of red cells or the degree of proteinuria, do not perfectly predict what we're going to find on biopsy. And that's why it's very important to get the biopsy, understand what the ISN RPS classification is. Is it a class, 2, 3, 4, 5? What is it? Is it a mixture? And then to understand what's happening in the tubulointerstitium, what's happening in the vasculature. You put all that together, and then you can come up with a treatment plan with the patient with shared decision making.
And would you think that is there any scenario where you would not need the biopsy in this patient?
In my opinion, I would recommend always getting the biopsy unless there is a contraindication in which it's impossible. But even then, it's very rare to have a contraindication. I'll give an example. Sometimes patients will come in already on anticoagulation.
Yes.
Let's say they've already been diagnosed with antiphospholipid syndrome, or there's some other mechanism, they've had a thrombotic event, and they are on anticoagulation. Even in that setting, what we are able to do, and I realize that some institutions maybe are not able to do this, so this might be a contraindication, but in my institution, for instance, patients will come into the hospital, we will bridge them with heparin, for example. We will stop the heparin, we will get the biopsy. And so my recommendation is to do whatever can be done to get that biopsy. I also do realize that perhaps in some parts of the world, it may be more difficult to do that.
Thank you. Andrea, do you want to comment this?
I just wanted to comment on this last aspect.
Yes.
I agree with Maria that, and also I suggest the biopsy in all my patients with lupus nephritis. However, if the question is, are there any scenarios where you can predict with more probability the histological lesion in the kidney, and so then you can theoretically skip the biopsy? In my opinion, yes, there is one scenario. For example, the young patients with the early occurrence of the lupus nephritis, where lupus nephritis occurs with nephritic syndrome. I think that in this case, you are pretty sure that the histological lesions are class 4 nephritis. And so it means that if you do not have the possibility to perform the renal biopsy, you can treat the patients as if it as the biopsy of a class 4 lupus nephritis. This is, I think, the only case when you have a clean case, patients with early lupus, with active serology, with a diagnosis which is sure, and with the development of nephritic syndrome, that patients, I think that it could be the only case where you can skip theoretically the biopsy.
Can I ask you back, Maria, is on this diagnostic biopsy, is there any hard data on the tubulointerstitial lesions and the vascular lesions that we wouldn't guess by the kidney syndrome? Is there any hard data on this diagnostic biopsy that this change the protocol for treatment and the prognosis and anything we are going to do next?
Yes, that's an excellent question. I think what's very interesting is when you think about the ISN RPS classification scheme that we all use, the class 1 through 6, that is just based upon glomerular lesions. And I think that many of us sometimes forget that, right? That is based purely on what's happening in the glomerulus. But what we've learned over the years from work from people like Marcus Clark, for example, and also from the Accelerating Medicines Partnership work and others across the world, is that the tubular interstitium is actually more predictive of long-term prognosis. So tubular interstitial inflammation, as well as tubular interstitial chronicity and fibrosis, is more predictive of long-term kidney outcome than actually what's happening in the glomerulus. And so therefore, I think it's very important to be able to look at that compartment, and it helps us try to understand what we can expect for that patient's trajectory and how we might want to treat them up front. And then also incorporated into that, we have the activity index and the chronicity index, which we are now using. For many years, those were not reported on the kidney biopsy, but then in 2018, with revision of the ISN-RPS classification, those have come back, and those are very helpful as well because, and we can talk about this perhaps later, but often we're in situations where we are doing repeat kidney biopsies down the road for a variety of different reasons in a patient with lupus nephritis. And so it's nice to know where we start from. What is the initial activity index and chronicity index? So that when we have to get subsequent kidney biopsies for various reasons, we will know if we are making progress, right, in terms of what's happening with immunologic activity. Is there progression of fibrosis, which will help us, I think about more of the non-immunologic treatments that we use to treat these patients. And then in terms of the vasculature, as you just said, yes, I think what I've learned over the years is that, and what we've seen is that presentations such as antiphospholipid nephropathy, which is a mimicker that we can see in our lupus patients, because as we know, about 30% of our lupus patients will have an antiphospholipid antibody. And we can see these microvascular changes in the kidney separate from the diagnosis of antiphospholipid syndrome. And it's very important to find those changes on the biopsy, because the treatment may be different. If there is a lot of thrombotic microangiopathy, one might choose to use anticoagulation in addition to immunosuppressives.
Mm-hmm.
And the other thing that we're finding on kidney biopsy is thrombotic microangiopathy, even without the antiphospholipid antibody, and that will raise the specter of other TMA syndromes, such as complement-mediated TMA.
Mm-hmm.
We're finding that. And in that situation, one might use a complement inhibitor in addition to treatment for the lupus nephritis. And so for all those reasons, I think it's very helpful to have the knowledge of the biopsy and looking at those different compartments so we can understand how best to treat our patient for the long term. Again, with the caveat that I realize that there are some situations in which centers may not be able to get the biopsy, but if one is able to get the biopsy, we recommend that they do it.
Thank you so much. Great talk. And she went away. She went to the diagnostic kidney biopsy, and we are talking about all this, but actually she had a class 4 classical lupus nephritis with no vascular abnormalities, activity 9 in 24, and chronicity index 2 in 12. After discussing with a new diagnosis of SLE and lupus nephritis, you discussed therapeutic options. She says she is very worried about her health and her kidneys and is interested in future childbearing. Also, due to her busy graduate school and work schedule, she prefers not to take intravenous medication. Maria, can you remind us of what was the year she came with this to you? So recent years, longer years, and how did you approach the treatment of this patient? And would it be different if this was on the current time, like 2024?
Yes, so this case actually was a more modern case. So she came in around the time that we had approvals of belimumab and voclosporin for the treatment of lupus nephritis. So I chose this case because she was more modern, but you're absolutely correct, Raquel, that if she had come in, let's say 10 years ago, I think our treatment choices would have been different because we wouldn't have had the data to support the use of what is being called, combination therapy or triple immunosuppressive therapy. And I think what's interesting is in this particular case, because she came in after we had those data, and because she was already telling us about the direction she wanted to go in, she did not want intravenous medications up front. And so that moved us away from, for instance, cyclophosphamide. And she was also very worried about her fertility. And we know that the Euro lupus nephritis regimen of cyclophosphamide at least one course should not have an impact on fertility, but I think there's still a worry in patients' minds. And so we decided to move towards the combination of mycophenolate mofetil and voclosporin. And we can talk about why the voclosporin as well. But I think just to point out, it's very nice that we have the excellent EULAR guidelines, which were recently updated, which and the KDIGO guidelines as well, that go hand in hand, that I think are very similar in that they give a variety of options that can be used for initial therapy of lupus nephritis. And within those options are these triple immunosuppressive regimens. And so we decided to go for that in this particular patient. Also, because she came in with such a high level of proteinuria, over 5 grams, we wanted to do what we could to bring down that proteinuria as quickly as possible, because we know that proteinuria itself is predictive of a poor long-term kidney outcome, and in itself is toxic to the renal tubules. And so that is why we added on the voclosporin to the MMF with the hope that we could bring down the proteinuria more quickly. But I think this is where, I think you've illustrated so nicely in the way that you've asked the question, this is where shared decision-making comes in with our patient. And at the end of the day, what matters the most is what the patient thinks is best for them in conjunction with their physician, thinking about what are they able to take with their life and their complications of their life, and what do they feel comfortable with. And in this particular situation, she was comfortable trying this combination with the thought that it would be kind of an intense regimen up front, but over the course of time, we could then quickly, hopefully, get her lupus nephritis under control, and then she can peel back some of the medications to have a more streamlined regimen going forward.
Perfect. Lupus nephritis, if no systemic lupus manifestations were there, were considered kind of a different disease, and the treatment was not exactly the same. So what can you comment on these? Our different lupus nephritis strategies went throughout the years regarding the general systemic lupus management. How did it change it? Where are we now on sunscreen protection, smoking cessation, and one of the most important things, the role of hydroxychloroquine in lupus nephritis patients?
If I can, as Maria said before, now either the new EULAR guidelines and the KDIGO guidelines, they recommend different options in a patients like these. And so the option who Maria chose is one of these options, MMF and voclosporin. The other option that could have been used is the MMF and belimumab. The reason for using belimumab and MMF instead of voclosporin could be that the patient has also skin manifestations, so outside the renal one. And then the other thing is that if I have correctly understood, that the patients didn't want to have intravenous therapy, and so even intravenous pulse steroids. And in the post-hoc analysis of the belimumab trials, it has been shown that the patients who did not use the pulse steroids had the same result as those who use steroids. And so it seems that the steroids the pulse steroids is not so necessary if you use belimumab. And so this could have been another option instead of voclosporin. I think that both of them, it is true that, as Maria told, that the patients has a proteinuria which is consistent, because it was 5, it is urinary protein creatinine ratio, but in any case, nephrotic levels of proteinuria. And so for the nephrotic level of proteinuria, there is some some more, yes, that there is some more indication to use voclosporin, although the patient has not class 5, and so has no podocytopathies. And so maybe I think in any case that these are the two options, in my opinion, most attractive, and for these different reasons could be, one can choose one or the other one. Regarding the other question on hydroxychloroquine, it has been shown that the addition of hydroxychloroquine also in patients with lupus nephritis can protect the patients from the end stage renal failure, and and also we know that that hydroxychloroquine protect the patients from damage, and so I think that is a good addictive therapy. It is of course not the main the main therapy, but it is a good additive treatment. Regarding the smoking, I really recommend to all my patients. I spend a lot of time to recommend them to stop smoking. I think we know that, for example, smoking can in some way reduce the effect of hydroxychloroquine. And the other things is that smoking probably also have an action on the increase the cell apoptosis, and so it can increase the burden of the autoantigens which are exposed to the hyperreactive immune system of patients with lupus. And regarding the sun, it is of course mandatory for them, because it has really, and nowadays it has been really very well demonstrated that that the skin has a very active role in the pathogenesis of the disease, because keratinocytes produce interferon, and they produce interferon when they are exposed to ultraviolet lights. And so also before, we know that it is important but before we know them and we recommend them, because we know that the skin manifestations tend to relapse when the patients are exposed to the sun. But now we have also the mechanistic explanation on why they must avoid to expose to the sun. I think that probably since you know that the production of interferons by keratinocytes is also in patients without lesions, skin lesions. I believe that probably lupus start from the skin. It was this for a long time that I was convinced that the lupus starts from the skin, and now we have also a demonstration type. Of course, I think that it can be also it starts also in other organs, but I think the skin is one of the most important location where it could start.
Thank you, Andrea. I think I'm going to steal that from you to convince my patients to use the sunscreen and avoid sun. So lupus might start in the skin, and it's a good way. So till now, we already reviewed the lupus nephritis particular strategy, and we have seen all we can do from basic things to prevent lupus to keep being active. And Maria, I actually have another question for you about what else. And what about all the other adjuvants, the RAS inhibitors, the CGLT2 inhibitors in lupus nephritis? Is there current R data, and what are the recommendations?
Yes, and I just want to also emphasize, I love what Andrea just said, and I think even in my own practice, right, sometimes I get so focused on thinking about the immunologic therapies, the immunosuppressive therapies, and I don't spend as much time as maybe I should reviewing every visit, sun protection, are you wearing the broad brimmed hat? Are you wearing the sunscreen? Are you reapplying? So I just want to say, I think that was such an important point that we have to focus on that, the UV protection and the role of the skin in flaring all of systemic lupus. So that was great. And then in terms of your question, I like to think about the mechanisms of injury in lupus nephritis as being two large categories. The first are immunologic mechanisms. So for instance, immune complex deposition, complement activation, soluble mediators, immune aggregates. But then there's a whole other category of non-immunologic mechanisms of injury. And that is where we have to think about treating with these nephroprotective agents. So for example, RAS inhibitors. So it's very important in patients with lupus nephritis and proteinuria, which they all have, to treat with these nephroprotective agents. So we typically start with either an angiotensin receptor blocker or an ACE inhibitor first line. Those are very, very important because we know that in patients with proteinuria kidney diseases, those agents are nephroprotective and will decrease the progression of CKD. And they also treat blood pressure as well, and they're protective for the glomerulus as well. So those are important agents. And then after that, the question is that the hot topic, which you mentioned, is what is the role of SGLT2 inhibitors in lupus nephritis? And the answer in 2024 is we're learning. We're not exactly sure. The way that I view those particular therapies, I think they're fascinating therapies, and they've revolutionized the way that we treat chronic kidney disease and the way that we treat cardiovascular disease and heart failure. And in the large scale trials, thousands of patients. And when you see this protective effect in terms of decreasing progression of chronic kidney disease, decreasing cardiovascular mortality and events, parsing that down, there were two large scale randomized placebo-controlled trials of patients with CKD. However, the names of these trials were DAPA-CKD and EMPA-CKD. These trials did not specifically include patients with lupus nephritis, but they included patients with other forms of glomerular diseases. For example, IgA nephropathy, which is also an immune complex mediated disease. FSGS was included in there. And in those particular trials, there was clearly a protective effect in terms of decreasing progression of CKD and also an effect on cardiovascular mortality. So thus, we are now extrapolating from that to think about, well, could there be a benefit in patients with CKD, chronic kidney disease, in the setting of lupus nephritis? And this is being actively studied right now. We have some small case series from around the world, which have demonstrated that at least these agents seem to be safe. But we don't yet have the large-scale randomized controlled trials, but these are being studied. There was a plenary session at ACR Convergence last November. I believe April George was the presenter, where she looked at this target trial emulation, looking at this large data set of electronic medical record data from her institution and others, and looking at SGLT2 inhibitors versus another oral hypoglycemic agent in patients with lupus nephritis and diabetes. And there seemed to be a protective effect there in terms of CKD progression and cardiovascular mortality. So we're accumulating data. And I guess, I would love to hear Andrea's perspective and your perspective on this. How am I doing this now at my institution? How am I implementing this now in this imperfect world where we're still trying to get more data? This is what I'm doing. In my patients with lupus nephritis, who I've already treated with immunosuppressive therapy, and they're in a complete response, they're doing well from the lupus nephritis perspective, but they have chronic kidney disease, and they have what I think now to be chronicity and no more activity that I'm treating. We are adding in the SGLT2 inhibitors for the nephroprotective effects, but these are patients years down the road. In terms of, they have reduced EGFR, their active lupus nephritis is already treated, they're maximized on their ACE inhibition or their ARB, which is also very important. What else can I do to prevent progression of their chronic kidney disease and to give them cardiovascular protection. What else can I do? We can add those agents in. But I think the burning question in many of our minds is there a role for adding these agents in earlier in the treatment course? Because I think what's fascinating is these data coming out now suggesting that these therapies actually can impact the immunology of the disease. You probably have seen some of the basic science papers showing that these agents, for mechanisms I don't completely understand, can actually decrease autoantibody titers in lupus-prone mice. And so they're doing more than just impacting the hemodynamics of the kidney. There's something else happening immunologically, but we have to figure that part out. I think it's an exciting area. I would love to hear what both of you think.
Andrea, that was your next question. So we both want to know what do you think about this?
No, I agree that is a very interesting topic, that of the glyphosine. But there was some worries because since they increase the excretion of glucose, there is the risk in patients, immune suppressant patients, to increase the risk of infection, of urinary infections. But I agree with Maria that I think that there are some data now that from some clinical series or some case report which report a safety use of these drugs. And so I think that we should start to use them, because Maria told that they started to use, but a little bit late. Probably we have to use a little bit early, because we know that if a patient has a decrease in glomerular filtration rate, the prognosis of these patients is not so good. And so as soon as he or she develops a reduction of the glomerular filtration rate below the 60 ml, because glyphosine, for example, in Italy, cannot be used if the glomerular filtration rate is above the 60 milliliter. And so there is a cutoff. And so I think that if the patients that has a glomerular filtration rate below this threshold, I think that we should try to start to use it. I honestly have to say that I didn't start to use them, but I think that I have to start, definitely.
It's really interesting. You are making the patients lose glucose. So is this interfering with glycation of the proteins? Is this interfering with anything to have an immunological benefit? And I also do worry. I have used in some of the patients, but not with a protocol, with a methodological way. And actually, should we use it from the beginning with all the high steroids yet and the high rate of urinary tract infections and even fungal infections like candidias? We will need to know, and we trust you to do more clinical research on these patients. It's really interesting to know the mechanisms of the immunological aspect. And this is going quite interesting on the discussion, on theoretical discussion, and almost coming back to the patient. Maria, after doing all this that happens in a couple of minutes, reasoning about all what we're going to do, what is your plan for the scheduling of monitoring the patient? We're going to see a little bit later what you both choose for the patient, but you do all this, the initial approach, and then how do you schedule the monitoring?
And so I think, my typical schedule for a patient that comes in with active lupus nephritis like this, that's beginning initial treatment, is we're monitoring on a monthly basis initially, because we want to make sure that proteinuria continues to come down, eGFR is stable, or is improving, the patient is overall holistically improving. You know, as Andrea mentioned, she has a malar, you know, has malar rash, has extrarenal manifestations. Are those being treated effectively by our regimen? How is she doing? Is she tolerating? That's the other issue is how are patients able to tolerate all of these pills? I mean, you think about the burden of pills that we are asking. We're asking hydroxychloroquine, glucocorticoids, MMF, voclosporin, ACE inhibitor. And then if we add on SGLT2, it's like, oh, you know, so it's a lot of just counseling and making sure that our patients are able to do all of this, because it's very challenging. I'm not even sure if I could do it, quite honestly, myself. It's a lot. But we follow them. And then if you look at we think about EULAR guidelines, they beautifully outline some milestones for us. So for example, targeting a 25% reduction in proteinuria in the first 3 months, 50% reduction in 6 months, and then by 12 months, you want to reach that 0.5 to 0.7 level grams of protein. And so we have those nice EULAR guidelines that help us there. But really, at the end of the day, we're looking for improvement. We don't want to see worsening. I don't want to see proteinuria worsening over the first 3 months, or eGFR, you know, decreasing over the first 3 months. I want to see stability and improvement over time, and we're monitoring and we're making sure that our patients are able to adhere to their medications and just close. And then as we get further along, we don't have to do monthly anymore. We can start seeing patients every 3 months, for example. But again, making sure that they're making progress and that they're reaching those goals.
Andrea, do you have anything to add on monitoring these patients?
I agree with Maria. Also, I used to see patients at the beginning, 1 per month, but in some cases, I have to say that if they start with very high levels of proteinuria and with the very bad nephrotic syndrome, maybe sometimes I see also them every week. In order to check the amount of urine and the blood pressure and so on. But generally, in the great majority of cases, I used to see them at the beginning every 1 month and then every 3 months. And then if they can achieve the remission, also every 6 months.
So absolutely, for sure, we shouldn't see the patient 3 or 4 months later. So really short, so we can achieve as quick as possible all the remission. So coming back to the patient, after shared decision making, the decision you both made was to start MMF, as you said, and voclosporin, in addition to glucocorticoids and hydroxychloroquine. After 16 months, urinary spot protein to creatinine ratio was 0.3. The GFR was 90, and dsDNA was a little bit, was not normal, but not so high, 45, and the complement C3 was not normal, but pretty much higher than it was before, so almost normal, 75. And they were better. And she was on kidney complete remission, and her prednisone was tapered to 5 milligrams a day. And after 8 months from this, she presents again with recurrency of her malar rash, nocturia again, and foamy urine. Her urinary spot protein to creatinine ratio was 2.0. The GFR was 70, dsNA a little bit higher, 65, and the complement was a little bit lower, 50. And she reports that she's not quite being able to take her medication regularly due to a school schedule, and she's experienced some nausea and diarrhea with MMF. Maria, what do you think is happening here? Is this a relapse? Is this a new lupus nephritis? Is there anything going on here? What did you do at this time?
So I think this was, instructive for me and for many of us, because in this particular case, she responded so beautifully. And she met all the targets that we hoped that she would meet. And then she comes in with what we think is a relapse of her lupus nephritis. And the question is, why did that happen? And that's where I think making sure first and foremost, is our patient able to adhere to these complex medical regimens? You know, before we call somebody refractory to a particular medication, we have to make sure, are they able to take that medication? I think in this particular situation, when I had that honest conversation with her, it was just too challenging for her to continue with these medications. But unfortunately, I didn't know that earlier, and she was feeling well, and I think she just stopped the medications because she wasn't tolerating them, and it was just too difficult. And then she came in with what I thought was a flare, and we decided to repeat the kidney biopsy because that is what we typically do. If we're worried about a flare, I want to see where she is now. What is the current class? How much chronicity has she accrued? You know, any other changes on the biopsy that I need to know about, and then go from there. But I think in this case, it was pretty clear that the complex medical regimen was too much. And I think it shows us also that our conventional medications, even, you know, mycophenolate, can be very difficult to take. It has to be timed, you know, before meals. It can have a lot of GI distress. In her case, she was experiencing that. So that was very challenging. And then we went ahead and got the kidney biopsy, and then we had to make some treatment decisions to treat then this relapse in a way that she would be able to take these medications and not have to take so many pills.
And she underwent a repeated kidney biopsy that showed class 3 plus 5 lupus nephritis, activity 4 in 24 and chronicity 5 in 12, and no vascular lesions this time. What was your treatment option, and why, Maria?
So here in this case, even though in the beginning she did not want intravenous medication, she had said that to us, I think she had realized now that actually it would be easier for her. The pills were too much. She wasn't tolerating them. She was now ready to try a very different regimen. And so we chose a different combination. And actually this combination Andrea had mentioned earlier, which is to start the urolupus cyclophosphamide regimen in combination with belimumab. And the other reason for this is we know from post-hoc analysis from the BLISS-LN trials that belimumab was particularly helpful in reducing the risk of recurrent flares, lupus nephritis flares, and also decreasing progression of her chronic kidney disease, right? There was a very nice effect there in terms of protecting her EGFR. And so because she's already had this, she already had her initial episode, now another flare, what can we do to protect her kidneys from losing you know, further parenchyma down the road? So this is what we decided to do, is to use this particular combination, and she was happy to do that.
Andrea, would you choose other options?
I think that in this case, this is probably the best option, keeping into account also the low adherence of the suspected low adherence of the patients. And so you perform one intravenous therapy, the other one is subacute. And so I think that it is a much more more acceptable for the patient, yes, of course, other option could have been to use MMF and to continue MMF and to start belimumab instead of voclosporin, or other option could have also been to use rituximab, for example. That is another option that could have been. But I think that I could have used the same option that Maria mentioned, and so the cyclophosphamide according to the Eurolupus project and belimumab.
Thank you. There's something funny about this new biopsy. The proteinuria was not as high as the first, and on the first one, there was no class 5, and now there is a class 5. And you chose to do a calcineurin inhibitor for the first one, and you're not choosing a calcineurin inhibitor for this one. Can you please comment on this, Maria?
So I think this is so interesting as well, Raquel. And I think what this has taught us over the decades that we've taken care of these of lupus patients is, again, this lesson that you cannot predict the pathology based upon the urinary parameters. You cannot predict. And you can see different levels of proteinuria. You know, you can have low levels of proteinuria and then have a class 5. You can have high levels of proteinuria and have a class 3 or 4.
Yeah.
And so which is why I think the biopsy is so important and helpful to be able to give us that information. But you make a fantastic point, and I think it illustrates it very nicely that we just can't predict. And yes.
And thinking theoretically, if now you could change something, would you have done a rebiopsy at 12 months of the first lupus nephritis, even if she was on remission, just to check if there is any activity there or not? Are you doing this? What do you think about this?
Yeah. Oh, that's such an important question. I think that we're trying to learn more about the role of repeated kidney biopsies. And there's different reasons why one may get a repeat kidney biopsy. So if there's the initial biopsy for diagnosis and prognosis, there's the biopsy that we call kind of at the time of potential flare or relapse, like she had. Then there are biopsies that we can do later down the road. For instance, in a patient who has achieved a complete renal response, and let's say they've been in complete renal response for at least 3 years, and I'm thinking about, again, the EULAR guidelines here of maintenance therapy, and you're getting ready to withdraw maintenance therapy, getting a biopsy at that point to see if there's still immunologic activity before you start to taper medications, because we know that, again, urinary parameters like red cells, proteinuria, don't perfectly predict what we see on the biopsy. We see a discordance between immunologic activity on the biopsy and what we see in terms of urinary parameters. And so there's specific circumstances, but then there are some people that prefer to do what's called a protocolized kidney biopsy, in which they do a biopsy no matter how the patient is doing in terms of their blood work or their clinical course. They do that biopsy either after initial therapy, so at 6 months or 12 months. And that's what we call a protocol kidney biopsy. And I have to tell you that I am not personally doing that at my center unless the patient was part of a research protocol. And there are clinical trials now ongoing. One of them is a wonderful trial that's actually led in Europe by Fred Husio and others, looking at this specific question. But I'm not doing it routinely in that setting. I am doing it in the setting of when I'm getting ready to withdraw maintenance therapy. So I am doing that, but I'm not doing the earlier protocolized biopsies.
Andrea, are you rebiopsying lupus nephritis patient?
Yes, like Maria, I am a biopsy patient with a flare. And we also published a paper where we demonstrated that the chronicity and activity histological lesion at the second biopsy are more predictive of a bad prognosis than those found in the first biopsy. Yes. So it's that in the second biopsy, they are also more informative. And the reason is that they give an idea of something that is the failure of the in some way the failure of the treatment. But again, as Maria, I do not use to perform per protocol biopsy, and I am waiting for the result of the re-biopsy study carried out in Europe, led by Fred Husio. And so, because it is true that now there is no data that support the use of the protocol biopsy.
Thank you. Maria, do you want to comment anything on this case? How she's doing? What do you want to comment?
Thank you. She's doing very, very well right now. And this new treatment course has gone well, and she's able to tolerate it. So I'm very pleased for her. And she's able to continue all of her things she's doing in school. And
perfect. Thank you so much for this wonderful discussion on this case. Thank you so much, Maria and Andrea, for sharing your insights in this challenging case. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.